So he has loss of appetite, he has poor oral intake, he's malnourished, he's constipated, he's got a grade 2 bed sore because he's spending most of his time in bed. He's having trouble with hypertensive episodes during dialysis, leading to aborting of dialysis or shortening of dialysis. And during the hospital admissions and after, the family has told you that there are episodes of delirium. Now, because each hospital admission sometimes requires more intensive care at home, the family has ended up taking a caretaker in the house, and that is adding to the financial burden of regular dialysis, of hospital admissions, and they come to you saying that, I don't want dialysis. So is this a point where we think of what else can we offer? And nephrology has now come up with multiple ways of discussing what other supportive care can be given to these patients. Sometimes it is called as renal supportive care, sometimes it is called as active medical management, sometimes it's called as comprehensive clinical care, sometimes it's called as non-dialysis management pathway. Basically what all of it is, and I'm going to discuss it as renal supportive care, is that there is integration of specialist palliative care and nephrology. And this care is more patient and family centered. The focus is on improving the quality of life of the patient, on preserving their independence, on active symptom management, aggressive symptom management, and on patient preferences. So what we do is going to be guided by the patient and the family. This is an interdisciplinary care in which, whether it is in an institute or whether it is in the periphery or whether it is in private practice, there is the involvement of the primary physician, the nephrologist, there may be the involvement of the palliative care physician, nursing involvement needs to happen, we need to include nutrition, the patient needs physical therapy, occupational therapy. And so how all these things can come together to offer the patient the best kind of personalized care there is. And a very essential component of renal supportive care is the principle of non-abandonment. So not offering dialysis or withdrawing dialysis does not mean that active disease management is not done, because that continues by the nephrologist, by the primary care physician, and by the other teams that are involved in care of the patient. So we have discussed about integration of palliative care within renal supportive care. Now, let's just take a couple of slides to talk about what exactly it is that palliative care does. So this is the WHO definition of palliative care. But if I had to talk about it simply, what palliative care does is that any patient...
We are not seeing your slides. Technical team, can you help?
Hello.
Yeah.
Hello.
Yes, now
it's shared. Now it's shared.
Yeah.
What about the previous two slides? Were they visible?
No.
Okay, I'm just putting them up in case anybody wants to go through the case again. A 75-year-old male with ischemic heart disease.
I think you mentioned it, so maybe we can. Nope.
Okay. So what we talk about in palliative care is, and this is the WHO definition of palliative care, that it improves the quality of life of patients and their families who are facing problems associated with life-threatening illnesses. But if I were to put it simply, what it would mean is that any patient with a chronic life-limiting illness with significant disease-related suffering, palliative care looks at the disease-related suffering. All disease-related suffering is divided into multiple components. There is the physical aspect, the psychosocial aspect, the psychological aspect, the spiritual aspect. And palliative care tries to look after all these parts. There are some myths of palliative care that it's about end of life, it means giving up, it means no more treatment, or it is only for cancer patients. This is not true. There are a multitude of conditions that palliative care can help with. So now getting back to renal supportive care. Apart from our gentleman in the case that we have discussed, who else could who else could benefit from renal supportive care? So anybody who is in a non-dialysis patient group, a patient who will not benefit from diagnosis or who has opted out of dialysis after discussion with his nephrologist, patients who are in a pre-dialysis group, that is, they may require dialysis in the future. Even patients who are undergoing dialysis but have a very high symptom burden will benefit from renal supportive care. Those who are considering withdrawal of dialysis, and those who have a dual diagnosis of cancer and end-stage renal disease. Now, coming to dialysis in the elderly and dialysis in those with comorbidities. This is a significant chunk of patients accessing dialysis, and the problems in dialysis in the elderly are quite a lot. So there can be patients with high comorbidity scores. They will not have survival advantage by introducing dialysis. Because patients on dialysis spent a long time in hospital, the hospital-free survival may end up being similar in both dialysis and non-dialysis group. Dialysis in the elderly is associated with the loss of independence and a reduction of QOL. And this is something that that is interesting to note, is that QOL of elderly dialysis patients is similar to those patients dealing with a terminal malignancy. So we were talking about how dialysis leads to loss of independence. Now, this was a group of 80 patients who were followed up over 2 years. They were all 80 years of age or older. And if you see the amount of patients who needed assisted living or complete supportive care, that is, they had to move into a nursing care scenario, a care home, increased with the initiation of dialysis. There is this excellent paper by Martag et al., which talks about patients over 75 years of age with a high comorbidity burden. So 3 or more comorbidities. So if you see the first graph, there is a definite survival advantage in patients who have been started on dialysis versus those who are on conservative management. This is for patients with no comorbidities. And in the second graph, patients with 3 or more comorbidities, the survival advantage is almost negated. So then how do we predict who is going to benefit from dialysis? What is their lifespan going to be like? There are multiple prediction models. The Australia-New Zealand supportive care guidelines are an excellent resource for everything related to renal supportive care. And so one of the prediction models which they talk about is the modified Charlson score, in which survival prediction can be done based on this scoring. There is another simpler prediction model, which is something that can be utilized in OPDs itself by the Renal Physician Association 2010 USA. It says that it's reasonable to withhold dialysis if the patient is over 75 years of age with 2 or more of the following risk factors. So either they will have a high comorbidity score, or they will have marked functional impairment, which can be determined by their performance status, or they will have severe malnutrition with a serum albumin of less than 2.5. And the fourth point talks about the surprise question. Now, the surprise question is actually used as a question which then decides when it is imperative that the patient receive palliative care. The question is that the physician asks themselves, would I be surprised if my patient died in the within the next 1 year? And if the answer to that is no, I would not be surprised, then that means that this is time for proactive palliative care, because the patient is nearing his end of life. He may have only a year of his life left. So 2 or more of these risk factors say that it is reasonable to withhold dialysis treatment. Now, once we talk about withholding dialysis treatment, we talk about a non-dialysis conservative pathway. There are multiple interventions that can be done, and there are multiple recommendations, multiple guidelines for this. I'm just putting up one guideline, sorry for the busy slides. So they talk about lowering BP targets, about what to do about statins. Is it okay to withhold statins? What interventions to be done for anemia, for hyperkalemia, for calcium and phosphorus? Is it essential for the high drug intake that the patient has? Can it be shortened in any way? So now let's come back to our case, now that we've discussed a bit about outcomes and prediction models and what can be done. So our gentleman had diabetic neuropathy. We would try to optimize his neuropathic agents, look out for side effects of them and try to work them out. Loss of appetite and poor intake. So advise small frequent meals, add prokinetics to the prescription, look for oral ulcers, look for loss of taste, things like soda bicarb mouthwashes to counteract loss of taste, treat his constipation. Bed sore care becomes very important because these patients may then go on to become bedridden. So treating the current bed sore, but also training the caregiver about how future bed sores can be avoided. In case of delirium, talk about place of care, maintaining a calm environment, adequate inputs in terms of sensory inputs, in terms of light, in terms of sound, using haloperidol SOS or on a regular basis if needed in terminal delirium. The patient who's talking about what to do with the dialysis. I don't want dialysis. This is where an honest discussion needs to be done. So if we're looking at ethics-based model of decision-making in dialysis, we are talking about the 4 principles of biomedical ethics. We talk about autonomy, talk about non-maleficence, about beneficence, about justice. Is the patient making an informed choice? What is the burden of the therapy that the patient is going to undergo? What is the burden of suffering that the patient is going to undergo? Is recommending dialysis ethical to this patient? Is there going to be, in the risk, if you calculate the risk-benefit ratio, are the benefits going to up the risks or not? What are we doing with the family's resources when we think about justice? And all these things need for us to be sitting down with the patient and talking about them, giving them adequate access to information, giving them a supportive environment to receive this information, discussions around quality of life, talking to them about the futility of certain treatments, what will CPR mean for them, what will intubation mean for them, what will ICU care mean for them, and involving family and all the stakeholders involved in the patient's care. Do I have 5 more minutes? Because the time says that it's time up.
Yeah, go ahead.
Thank you. So this is just an infographic describing where all the patient needs the primary care physician's help or the nephrologist's help in deciding what all needs to be done. And this importantly talks about advanced care planning, which I'm going to touch. So if you see that symptom control is something that will be there right from the initiation of diagnosis of CKD. And the importance or the necessity of symptom control increases as the disease progresses. So symptom management is something that we need to look at very carefully. I'm not going into details of symptom management because it is an exhaustive aspect, and there are many guidelines about symptom control in renal supportive care. Advanced care planning needs to be done at a certain point in the illness. It's not always easy to decide when to talk about it, but especially after a patient has had a bad admission and has come out after that, to talk to them about it. Suppose you might need an admission like this again. Suppose you might need to go into the ICU again. What do you think would you like to do? So talk about their patient preferences. And at every step, support their decision, make sure they have the information enough to make a shared decision. Now let's rewind back to the first instance when we spoke about this case. So at 75 years of age, frailty is has already set in, the patient is already wheelchair bound. What would you do at this step if the patient walks into your OPD? We need to give the patient adequate information, what continuing dialysis would mean for him, what it means in terms of survival benefit. We need to have the discussion about dialysis withdrawal or about not initiating dialysis because dialysis is an informed choice, and the patient needs to know that, and it is not just something which has been directly told to them and they have to do. Then we need to talk about advanced care planning. We need to do if there is something in which the patient and the doctor are not in agreement in terms of decision making, then we need to involve the principles of medical ethics and seek help if needed. So that could mean a second opinion, that could mean involvement of a medical ethics team if you have the access to it, that could mean referral to a palliative care physician. What all needs to be discussed in advanced care planning?
I think there was some problem about timing. Your timing is actually another 15 minutes you have. There is no time.
Okay, thank you. So what all needs to be discussed in terms of advanced care planning? And more importantly, when to initiate the discussion, how to talk about advanced care planning. If you see, there are so many aspects that I've put up on this slide. It is not a discussion that can be done at a single setting. It may not always be possible. It may require multiple visits. It may require giving small chunks of information and then waiting for the next visit to give the next chunk of information. It may mean just putting this idea into the patient's head and then giving them adequate time to go back home, talk with their family, and then come back and discuss with us. So what would the patient like to do? Advanced care planning talks about patient preferences, but not in the sense that this decision is entirely in the patient's hand or entirely in the family's hand, because decision making is at its best when it is done with the medical team as well as the patient in the same space, in the same room. And so what we are trying to do is basically bring the focus of the treatment back to the patient themselves by asking them what they would prefer. Preferences in terms of use of vasopressors. Would they want CPR or ventilation done to them? Admission to the hospital. At some point of time, patients reach a point where they say that they would not like to be admitted to the hospital anymore. What home care can be done for them? How we can help their symptom management at home is also something that needs to be done, that needs to be discussed concurrently. So admission to hospital or admission to ICUs, undergoing major vascular surgeries or major cardiac surgeries, artificial hydration, feeding through Rice tube, feeding through pegs, feeding through a peg, or IV fluids. Because patients may not be always lucid towards their end of life, because cognition is affected, it's essential that all these decisions are made beforehand so that the patient and the family has time to discuss them. These could be put down in writing or it could just be verbal. And it also takes away the guilt aspect from the family when their patient suddenly deteriorates and they don't know whether their mother or father would want to be put on a ventilator or would want to be kept on a Rice tube feeding, whether they would consider this a kind of forced feeding. It's also important to establish a healthcare proxy. So in the event of the patient decides that in the event of my deterioration and me being unable to make decisions, who would I assign as my healthcare proxy? A spouse, a child, a friend, and also to decide what would place of care be like. This includes things like, would you prefer to die at home, in a hospice, in a hospital? What are the different options that we can offer? assuring the patient that we will try and manage all their symptoms in home, because that is a major reason why patients decide to go from home to hospital, because they are suffering in terms of physical symptoms, or their family cannot see them suffering, or the family feels that they are being inadequate in some way when it comes to care of their loved one. So all these things are part of advanced care planning, and they may be done by the patient. They may be initiated by the patient themselves. They may be initiated by the treating doctors. They may be discussed with nurses, and they can be done over multiple episodes or even in the same sitting, but giving them adequate time to decide and discuss. So I'm going to end with a few resources which are especially important for us in the Indian scenario. Early in April 2020, the ICMR has come out with consensus guidelines on do not attempt resuscitation. And this includes a sample DNAR form, which can be used by hospitals or nursing homes all over. All you need to do is add your hospital's name. And it is something that is signed by the patient or by a caregiver, her healthcare proxy. And it was a good step towards sort of streamlining discussions about advanced care planning or discussions about withholding or withdrawing treatment. When we talk about advanced care planning as doctors, we're also always worried about the legal aspects, about what this might mean. Will we be sued? Are we saying the right thing? There is a lot of information about advanced care planning out there in the Indian context, and this website, that is Vidhi